Hey everybody, how you doing? Tim Cassidy here. I've got Dr. Jeff Riggenbach here with us. He is an award-winning author, trainer, coach, and certified cognitive therapist who is an international expert in CBT and personality disorders. Dr. Riggenbach has developed and overseen CBT-based treatment programs for mood disorders, anxiety disorders, addictive behavior disorders, and personality disorders. He's trained over 30,000 professionals in worldwide and has written several books. His most recent one, released just several months ago, it's called The CBT Toolbox, second edition, a workbook for clients, clinicians, and coaches. And it's available on his website if you want to go check it out. His website is jeffriggenbach.com. That's JEFFRIGGENBACH.com. So Dr. Riggenbach is here with us today, and he'll be delivering a 3-hour virtual workshop entitled Suicide and Parasuicide in BPD, Evidence-Based Strategies, right here on the platform, onlinececredits.com. That's going to be Friday, February 25th, 2022, from 10 a.m. to 1 p.m. Central Time. That's 11 to 2 Eastern and 8 to 11 Pacific. Dr. Riggenbach, thanks so much for joining us today.
Absolutely. It's good to be here with you.
Oh, great. I'm excited to have you today. I actually have, what I'd like to do is give folks kind of a preview of what they can look forward to in your workshop coming up in February. So I've got a couple of burning questions for you, if that's all right.
Absolutely.
So the first one I got for you is, can you touch on some of the more common treatment challenges therapists bring you with regard to their clients with BPD, and how your skills-based workshop helps these therapists overcome their challenges treating the disorder?
Yeah, that's a good question, Tim. I think it's, really probably, and this might sound a little generic, but almost religiously, when clinicians will come through the door or the virtual door, wanting to do consulting with their borderline personality disordered patients. The most common thing I hear is people saying versions of the strategies that they've been using for, their depressed individuals and their clients with anxiety and their clients with substance use disorders that have been effective with almost all of the other client populations they work with are just not working with this borderline population, and just kind of throwing their hands up. And I'm always reminded of the old Mark Twain quote, if all you've got to hammer, everything you see looks like a nail. And, growing up a farm, that maybe resonates with me a little more than many of your audience. But I can tell you from experience that you can do a lot with a hammer. But when you get to a project that actually does require a wrench or a screwdriver or whatever, there's only so many angles that you can try to use that hammer. And eventually you see that it's just pretty hopeless. And I think that is the experience that I see most often with clinicians that I work with. And I remember actually in my own personal experience, when I first started in the field, I was going to graduate school full time. I was working weekends and mostly overnights in the psychiatric hospital. And I would see these clients come in, these individuals with, suicidality and depression and schizophrenia and psychotic disorders and substance use disorders, intoxicated and all these other conditions. And occasionally I'd see somebody come in with what they called a personality disorder. And it was just intriguing to me from the very beginning, is that this diagnostically, I realized pretty quickly, was just a completely different animal, and that it was sort of demoralizing and intriguing at the same time for me to see that these clients were not getting better, like clients with all these other diagnoses were. And now all these years later, sort of on the flip side, when we now have evidence-based treatment for BPD, sort of the discouragement has turned to hope and excitement. And I just really do have a passion for sharing these evidence-based strategies. And you mentioned skills-based. It is skills-based, but we're going to do some DBT. We're going to incorporate some CBT. We're going to incorporate some schema therapy, some deeper level work as well. So you really do need a completely different set of tools in your toolbox, if you will, to treat this condition. So it's partially about the skills, but it's also maybe even more so about the process and the structure and following the protocol that we need to treat this population just differently than we do everybody else. And so I really do have a passion for sharing those evidence-based strategies with clinicians to make their lives better, and also for their clients. I can't tell you how many clients I've seen on the other end of that who did receive treatment from clinicians who offered this sort of treatment and just had so much more hope in their life. And ultimately, as clinicians, we want effective treatment outcomes. But really what we're in this for, I think most of us, is to help people have better lives. So I really do get excited about that.
That's awesome. And then that's kind of the double whammy too, if you can kind of help the clinicians move along in the treatment of BPD, and on the flip side, have clients that experience those outcomes, those positive outcomes at the same time. So that's great. The second question I have for you is that a lot of clinicians think of elevated risk and liability when it comes to this population, people with a BPD symptom profile. Do you think that there's a certain kind of therapist pedigree that's more successful with BPD clients, or can any skilled and dedicated clinician effectively treat this disorder?
Yeah, pedigree, I don't think so necessarily. I mean, whenever I hear questions of this nature, concerns of this nature, I oftentimes think back to Sean Christopher Shea, who was the longtime medical director at Dartmouth's Psychiatric Hospital. And he did a series of lectures at our facility a little while back here now, but I remember him talking about, really describing traveling the country, providing expert testimony in cases where individuals with BPD were suing the clinicians, or the individual with BPD had completed suicide and the family member was then suing the clinician. And I remember him saying that the most common scene that he had seen in courtrooms around the country actually looked a little something like this. The attorney would say, well, gee, clinician so-and-so, I've got your medical record here. I see this person's, attempted suicide 9 times. And then here on this line, or axis 2, if you were dealing with an older chart, you've got deferred, deferred, deferred. I mean, did you not realize what you were dealing with here? And if you didn't realize what diagnosis you were dealing with, how in the world could you have offered effective treatment? So I found it a little bit ironic and a little bit comforting, a little bit powerful at the same time, in that on one hand, we have what we believe to be some pretty strong clinical rationale for making the diagnosis and offering the treatment. But here he's offering a pretty compelling legal rationale that it's actually the clinicians that do dive into this and don't shy away from it, fearing litigation. I mean, we obviously have to provide evidence-based treatment that works within the practice guidelines. We all have to practice within the regulations of our states and provinces and countries. But it's those clinicians that really did that didn't shy away from it because they were anxious about it, that got the treatment that they needed, the training that they needed, and then really dove into it, it was really best for the clinician as well as best for the client. So in terms of pedigree, I mean, I don't think so necessarily. I mean, part of your training, again, I sound like a broken record here, but part of your background needs to include training for diagnosing and treating this population specifically. But otherwise, I almost think it depends more on personality. I think personality is a pretty important factor. Are we able to I heard this a number of years ago in a training also, and I remember thinking it was kind of silly at the time, but the trainer had a more psychodynamically oriented background, and he was kind of walking through the history of the BPD diagnosis. And I remember him talking about this theorist that talked about the concept of the adolescent adult. And I remember him making the statement that the better you are at parenting teenagers, the better you will be with treating people with BPD. And I remember thinking that was just kind of clinically lazy or whatever, and he maybe didn't have too much else to offer, so that might have contributed. But over the years, I've really seen there may be some truth to that. Certainly some common factors, and maybe the biggest one's flexibility when parenting adolescents and when working with this population. We got to be flexible to meet them where they're at and to be able to validate and challenge, to be able to not get our buttons pushed when working with them. And maybe that's the third one. I know we got to wrap up pretty quickly here, but it is just, and I'm sure this doesn't come as a shocker coming from a cognitive therapist, but I really do think the way that we think about clients in session while dealing with them makes a big, big difference. When they're exhibiting profanity and calling people names and demeaning. And I mean, we've had stuff taken off the walls at the treatment centers and all kinds of things. But in the middle of all the ugliness, just to be able to remind myself that underneath all of that volatility and throwing staplers and whatever else is really just a very scared and sick and hurting little boy or girl. That makes a big, big difference in my empathy, my ability to be in a room with them while we're having these conversations. And so I see clinicians just getting frustrated. They shouldn't do this. They shouldn't do that. They have BPD. Yes, they should. I mean, it's a symptom of their condition. We don't expect diabetics not to come in with, blood sugar out of whack. It's part of what they have. And so I could talk for a long time, but I would say training in assessment, diagnosis, and treatment of the condition, a flexible personality, the ability to connect with them and develop rapport with them, to work with them on a long-term basis, and then how we think about them as we do that are really big keys in working effectively with this population.
Right. So training and consultation for sure. Just to realize as clinicians that we're never alone, right? We might be alone in the therapy room, but there's always time and space and resources on the back end to get consultation, get more training. And so that's good for people to keep in mind. But that was an awesome, very well thought out and thorough answer. I appreciate that. So
yeah, I mean, more resources today than we've ever had for dealing with this population.
absolutely. Well, thanks so much, Dr. Riggenbach. That was an awesome preview. I know we're all looking forward to attending this one in February coming up. So guys, if you haven't registered yet, be sure to click the link in the description of this video here to lock down your ticket today while registration is still open. Thanks again, Dr. Riggenbach, and we look forward to seeing you here in February. I know I'll be sitting on the front row.
Sounds good, Tim. We'll see you guys then.
All righty.